So today I'll be presenting a journal. The journal is The Breast, with the title of the study is Mastectomy versus Radiation of Secondary Sites in Stage 4 Breast Cancer, which is an analysis from a National Cancer Registry. The date of publication is 15 October 2021, and the authors Nadeem Bilani, Marita Yagi, and Olivian Main et al. It is conducted from USA in Florida and New York. So the clinical question which is asked in this study is in patients with de novo stage 4 breast cancer with metastasis, whether metastatectomy of the secondary site has any benefit over radiation of the secondary site. So the background was that breast cancer is commonly diagnosed cancer in women, and at diagnosis 6% have distant organ metastasis with de novo stage 4. The overall survival in these patients is 27%, and the mainstay is palliative systemic therapy. Surgical treatment is only done in primary sites and only for palliative purposes. The loco-regional treatment of primary site, whether it is surgery or radiation, it may have improved survival. And these studies have only focused on loco-regional treatment of primary sites. So no study on the secondary metastasis site is done. There was a study done by these very people in patients with a combined approach of resection of primary and secondary sites in patients with limited metastasis, and this was associated with improved survival. Another study done by the same authors have shown that metastatectomy alone without primary site surgical resection was associated with improved overall survival compared to no surgery. Other retrospective single-arm prospective trials have investigated the survival benefit of loco-regional therapy in the lung, prostate, and colorectal cancers as well. So they have a retrospective 2-arm cohort study, and they have obtained their patients from National Cancer Database for de novo stage 4 breast cancer between the year 2010 and 2017 who received loco-regional therapy. These patients were subdivided into 5 cohorts based on the site of metastasis. It was classified on the basis of bone-only metastasis, brain-only metastasis, liver-only, lung-only, and metastasis involving more than one site. The outcomes which were measured were to assess the socio-demographic and clinico-pathological factors which were associated with the use of mastectomy versus radiation of secondary sites in patients with de novo stage 4 breast cancer, and whether the radiation or metastatectomy was associated with improved overall survival. These patients were assessed based on their socio-demographic and clinico-pathological characteristics based on the loco-regional therapy which was adopted. And multivariate regression models were applied for the most important factors that were associated with the choice of loco-regional therapy at the secondary site. The Kaplan-Meier model and log-rank testing was used to explore the differences in the overall survival by the approach of loco-regional therapy. The Kaplan-Meier models were adjusted according to the confounders, and multivariate Cox regression models were applied for overall survival for each cohort to ensure that the loco-regional therapy was independent of any confounders like age, sex, race, breast cancer receptor subtype, and Charlson-Deyo comorbidity score. The results which they found, these are the patient characteristics on the left side, which affected the choice of loco-regional therapy in the retrospective data. So in the first column, we see that most patients had more than one site of metastasis. Like 63.1% patients had presented with more than one site, and single site involvement was seen most commonly in the bone, which was 31.6%. The brain was 2.9%, lung was 1.3%, and liver was 1.1%. Patients with liver and lung as single site metastasis frequently were subjected to metastatectomy, and patients with brain, bone, and multiple sites were subjected more often to radiation therapy. Age was also a significant factor which created a difference. Less than 50% had higher chances of being subjected to metastatectomy than the patients which were 50 to 70 years and more than 70 years age group. Race had no significant role, and receptor status of the breast cancer had no significant role in the choice of therapy which was given. Even the grade of the tumor did not have any significant difference in the choice of the locoregional therapy which was adopted. Overall, radiation was used more commonly to target the secondary site. So 81.2% patients were subjected to radiation, and metastatictomy was performed in 18.8% patients. Now the survival analysis, the multivariate Cox regression model controlled for confounders of survival showed that patients who underwent metastatictomy of a secondary site had better overall survival compared to those who underwent radiation therapy. And metastatic site involvement was additional independent predictor of overall survival. So multivariate Cox regression was conducted to evaluate differences, and these showed that patients who underwent metastatictomy at secondary site had better survival. So age in these Cox regression model overall survival, we see that the hazard ratio for radiation kept as 1 and metastatictomy with relative to radiation showed that patients who underwent metastatictomy had better overall survival than the radiation. Then the site which was involved, like the bone, brain, liver, lung, and more than one site. So compared to the bone, these parameters are compared with the bone, and liver and lung had better overall survival than brain, bone, or more than one site which was involved. Age was also a significant predictor, with increased age correlated with decrease in the overall survival. The Charlson-Deyo comorbidity score according to the grades 0, 1, 2, 3. So higher the grade of the Charlson-Deyo comorbidity was associated with worse outcomes. And receptor status of the patient in triple positive patients, it was had better overall survival than triple negative. So these are the log. These are the log rank testings which are done. The green curve shows the metastatictomy, and the blue one shows the radiation therapy. So in bone only, there was the area is much less, but there is still an improvement in the survival. In brain only, also the curve is the area is very narrow, but still there is improvement. In liver and lung, we see a major area which is there is a significant difference, large difference in these areas, which shows that it had a better response to metastatictomy. And more than one site, also there was a good response to metastatictomy than compared to radiation. These are the difference in median overall survival which are seen, and in radiation and metastatictomy they are compared. So when there was only single site of metastasis, in bone only there was a median overall survival benefit in months, which was in bone that it was a 42.4, and in metastatictomy 50.3. In brain, liver, lung, it is compared. So the maximum is seen in lung only metastasis. So the maximum difference in the overall survival was seen in maximum in the lung, followed by the liver, and followed by more than one site of involvement. So local treatment, which was targeting the secondary lesions, either by radiation or surgical resection, resulted in improved overall survival. And patients with metastasis to the lung and liver were more likely to undergo metastatictomy, while patients with bone, brain, and more than one site were likely to undergo radiation. The reason for this could be that widespread use of surgical resection for liver and lung malignancy, whether it is a primary or secondary. When survival benefit of the liver metastasis was assessed in other studies, there was inconsistent benefit was found and could not be correlated, but some evidence does exist for improved survival from radiation to breast metastasis, to liver metastasis in colon cancer in undissected tumors. The lung metastasis from breast cancer most often are peripheral in location. Therefore, there could have been high rates of surgical resection. And various multi-center trials have shown complete resection in 85% lung metastasis. Other small population studies have shown improved survival in isolated lung metastasis in secondary tumors. In a prospective study done, a survival benefit of 79.2 months was seen in the resected secondary lung metastasis, which was consistent with this study of 74.6 months. Contrary to liver and lung metastasis management, the brain metastasis have traditionally been managed with whole breast radiation. Not enough evidence is found on management of surgical resection for palliation of bone metastasis. So probably in this study also, we did not get a lot of patients which underwent metastatectomy for bone and for brain metastasis. These management practices go hand in hand with the study analysis findings with better survival in liver and lung than brain and bone. Current NCCN guidelines recommend systemic therapy as mainstay of treatment in stage 4 breast cancer in the form of chemotherapy or hormone therapy depending on the receptor status. The benefit of loco-regional therapy needs to be studied with more prospective studies. The strength of this study was that the data was a retrospective collected from a consistent and reliable national cancer database that undergoes internal audit and has and can be reflected in real clinical practice. The limitations are that it is a retrospective study. Prospective randomized controlled trials must be done. Various confounding factors in the application of loco-regional therapy of choice were not properly addressed in the bone, brain, liver, and other metastatic sites. Primary cancer site management was not mentioned. Whether the primary cancer site was managed or it was left just like that. The quality of life of patients with increased overall survival also needs to be assessed, because prolonging the number of months of life must also be associated with a good quality of life. The secondary metastatic site size, number, and location of the metastatic site, the exact location, whether it is peripheral or whether it is central, this data was not mentioned. Whether the resection was R0 or R1, whether a debulking was done or a complete resection was done, was not mentioned. The visceral organ involvement, whether it was unifocal or multifocal, was also not mentioned. Progression-free survival or disease progression data was also not available in the months that the patient survived. And baseline characteristics were not matched systematically. So the conclusion from this study was that surgical resection of metastatic sites in patients with de novo stage 4 breast cancer is associated with significantly improved overall survival as compared to radiation of these secondary lesions, regardless of the organ involved and number of secondary lesions. Improved overall survival is most apparent when secondary site involves the liver and the lung. Both radiation and surgical resection should be considered in clinical practice, depending on the clinical indication discussed in the multidisciplinary team. So is this a new study? So no, metastatectomy has been previously done, so it's not a new study. Is it true? So it's not true, because retrospective studies should be present with proper matching. And can it be followed in clinical practice? So no, it needs further prospective studies before accepting it as a standard treatment modality.